So, pancreatic ductal adenocarcinoma staging and assessment of resectability. AGCC 8th edition TNM staging system for pancreatic ductal adenocarcinoma will see. TNM system remains the gold standard and is useful for general prognostication based on the disease stage. However, the TNM system is completely retrospective in nature and requires surgical pathology review for localized disease and does not include any information relevant to real-time decision making and the assessment of patient with newly diagnosed pancreatic ductal adenocarcinoma, except for patients with clear radiographic evidence of distant metastatic disease. Historically, patients have been clinically staged using TNM system, but this has proven to be an inaccurate method. So this is TNM staging. T1 is less than 2 cm in the greatest dimension. T2 is 2 to 4 cm in the greatest dimension. T3 is more than 4 cm in the greatest dimension. And T4 is involvement of the celiac, superior mesenteric and common hepatic artery. And 1 is 1 to 3 regional node and 2 is 4 or more regional nodes. So this has to lead to the consensus criteria for resectability, while abundance of literature have focused on the anatomical resectability of the localized pancreatic ductal adenocarcinoma, and it is becoming more widely accepted that biological features such as factors that suggest that the presence of distant metastatic disease and patient's conditional factors like factors that predict whether or not the patient will tolerate proposed treatment should be considered when making treatment decisions and loco-regional and systemic. These factors are also important in planning treatment sequences like neoadjuvant or upfront surgery, and the concept of tumor removability, that can tumor be technically removed from the patient and should be distinguished from resectability, that tumor removability while factor in biologic and patient condition features, and the combination of anatomic, biological and conditional resectability constitute clinical resectability. Anatomical resectability, then biological features like presence of distant meds, and conditional factors like presence of factors that predict whether or not the patient will tolerate the proposed treatment. So all these three parameters, they form clinical resectability, that is resection likely to provide clinical and oncological benefit of the patient. So surgical staging, surgical anatomy, the evaluation and treatment of localized pancreatic ductal adenocarcinoma require understanding of the anatomy of the pancreas and nearby structures. And the pancreas is elongated gland in the retroperitoneum that crosses the midline at L2 vertebral body. Pancreas is bound anteriorly by the stomach and posteriorly by IVC aorta, the IVC aorta, adrenal gland, left kidney, and the descriptive anatomy of the gland is very grossly separated into four components. The head is the rightmost portion and sits within the duodenum C loop, includes parenchyma to the right of the superior mesenteric vessels and contains uncinate process which projects inferior-medially extending to the right lateral border of the superior mesenteric artery. The common bile duct runs within or rarely just posterior to the pancreatic head and enters the duodenum at the ampulla vater, usually with the main pancreatic duct. Moving leftward, the neck of the pancreas lies anterior to the superior mesenteric vein or portal vein axis. The superior mesenteric vessels run posterior to the pancreatic neck and course inferiorly across the anterior border of the third portion of the duodenum. The body and tail of the pancreas extend to the left of the superior mesenteric vessel, and the gland transitions distally into the pancreatic tail anterior to the left kidney and courses towards the splenic hilum. Anatomical resectability criteria. So several organizations have published consensus definition of the anatomical resectability, including the IAP, that is International Association of the Pancreatology, and the central tenet of anatomical resectability is the likelihood of achieving margin negative. So anatomical is achieving margin negative resection, that is R0 resection, and this is influenced by the degree of involvement of the tumor and peripancreatic blood vessels, that is SMV portal vein, SMA, then common hepatic artery, celiac axis. Anatomical resectability of the tumor with a high probability of R0 resection. Borderline resectable tumor have high probability of R1 resection, that is microscopically positive margin. And resection in the absence of neoadjuvant treatment, and resection in the absence of the neoadjuvant treatment. And locally advanced tumor have a high risk of R2 resection, locally advanced tumor. And residual macroscopic disease data from large institutional cohort studies demonstrate poor survival in patients who undergo surgery, that is first approach, resulting in R1 resection margin. While cross-sectional comparisons are not possible, similar survival has been reported between patients with non-metastatic, non-resected pancreatic ductal adenocarcinoma who receive intraoperative radiotherapy. Systemic chemotherapy with or without radiotherapy, suggesting a lack of oncological benefit of upfront resection that results in R1 resection margin. So consensus anatomical resectability criteria are summarized. Resectable lesions do not contact the visceral arteries, SMA, CHA, celiac axis, and do not distort the SMV portal vein axis with less than 180 degree contact. Portomesenteric venous reconstruction, and if indicated, is feasible. Borderline resectable lesion involve visceral vessels, arterial contact defined as less than 180 degree, and if SMV portal vein involvement exists, reconstruction is technically feasible. Locally advanced lesion more than 180 degree contact with the aforementioned arteries and occlusion of the SMV portal vein such that no reconstruction remains an option. So this was about the anatomical staging. Now biological staging. The concept of biological staging in pancreatic ductal adenocarcinoma was first described by Wendy Anderson in 2008. Biologically, borderline disease was defined as having suspicious for but not diagnostic of metastatic disease. On cross-sectional imaging in patients with biopsy-proven regional lymph node involvement. This definition was updated in 2012 to include CA99 if more than 1000 units per ml in the absence of biliary obstruction, which is often associated with an elevated CA99. Several groups have demonstrated pre-op CA99 level associated with the poor prognosis. And for Farron and colleagues reported 176 patients who underwent upfront pancreatectomy for pancreatic ductal adenocarcinoma between 1985 to 2004 with documented preoperative CA99 values and total bilirubin of less than 2 mg per dl. Patients with lower CA99 values were more likely to have N0 disease and lower T stage. And patients with CA99 values less than 1000, they had a median survival of 2.3 years compared to 1 year for CA99 above 1000. Additionally, following pancreatectomy, patients who had CA99 decrease had improved overall survival compared to those with an increase, and the strongest association appeared to be a cutoff of 200 unit per ml. Cutoff of 200 unit per ml. Barton et al. Received 143 patients who underwent upfront pancreatectomy, and Mayo Clinic between 2001 to 2006 and reported that CA99 less than 120 unit per ml were associated with C99 less than 120 unit per ml associated with the improved overall and recurrence-free survival. And Heidelberg group published a single institution series of 1600 patients who underwent upfront surgery for potentially resectable pancreatic ductal adenocarcinoma, and the authors demonstrated an association between preoperative CA19-9 and resectability. Fewer than 70% patients with CA19-9 more than 500 unit per ml underwent pancreatectomy. Additionally, the authors also reported the median overall survival was 5 and 5-year survival decreased with the CA19-9 increased, and with preoperative CA19-9 unit less than 100 unit per ml had a median OS of 27 months, 5-year OS of 19 to 27%. Patient with CA19-9 100 to 500 may have a median survival of 20 months. So if CA19-9 is less than 100, then median survival is 27 months. If it is 100 to 500, median survival is 20 months, and 5-year OS is 12%. And patient with preoperative CA19-9 if more than 500, then median OS of 12 months. So only 7% of the patient with CA19-9 levels of 500 or 1000 unit per ml were alive at 5 years, and no patients with a preoperative CA19-9 value more than 1000 unit per ml alive at 5 years. Majority of patients undergo upfront dissection for pancreatic ductal adenocarcinoma, hepatitis N1 disease, and which at minimum transit of stage 1 to B. This is based on the 8th ADCC system. Median survival is 24 months or less. And the importance of biologically borderline pancreatic ductal adenocarcinoma was demonstrated nicely by Zhang and colleague, and who showed that nearly 50% of the patients with biologically borderline resected pancreatic ductal adenocarcinoma progressed while receiving neoadjuvant chemotherapy, chemoradiotherapy with or without systemic chemotherapy. So around 50% of the patients, they will progress from resectable to borderline resectable who have receiving neoadjuvant chemoradiotherapy. IAP consensus determining definition of biologically borderline pancreatic ductal adenocarcinoma is a potentially resectable tumor with the clinical findings suggestive but not a conclusive of distant mats, indicating including CA19 level more than 500 unit per ml, regional lymph node mats diagnosed by biopsy or PET-CT. Thank you.